In this presentation, we will discuss medication-assisted recovery. What is addiction? The American Society of Addiction Medicine describe addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. Drug addiction, like many diseases, is marked by periods of recovery and symptom reoccurrence or relapse, and often requires continual effort to manage. The American Medical Association, the National Institute on Drug Abuse, the Substance Abuse and Mental Health Services Administration, and the National Institutes of Health all similarly describe addiction as a long-term and relapsing condition characterized by the individual compulsively seeking and using drugs despite adverse consequences. Addiction, clinically referred to as substance use disorder, is a complex disease of the brain and body that involves compulsive use of one or more substances despite serious health and social consequences. Addiction disrupts regions of the brain that are responsible for reward, motivation, learning, judgment, and memory. People feel pleasure when basic needs such as hunger, thirst, and sex are satisfied. In most cases, these feelings of pleasure are caused by the release of certain chemicals in the brain, which reinforce these life-sustaining functions by incentivizing the individual to repeat the behaviors that produce those rewarding feelings, such as eating, drinking, and procreating. Most addictive substances cause the brain to release high levels of these same chemicals that are associated with natural pleasure or reward. Over time, continued release of these chemicals cause changes in the brain system involved in reward, motivation, and memory. The brain tries to get back to a balanced state by minimizing its reaction to those rewarding chemicals or releasing stress hormones. As a result, a person may need to use increasing amounts of the substance just to feel closer to normal. The individual may experience intense desires or cravings for the substance and will continue to use it despite harmful or dangerous consequences. The person may also prefer the substance to other healthy pleasures and may lose interest in normal life activities. In the most chronic form of the disease, a severe substance use disorder can cause a person to stop caring about their own or others' well-being or even survival. The initial and early decisions to use substances are based in large part on a person's free or conscious choice, often influenced by their culture or environment. Certain factors, such as a family history of addiction, trauma, or inadequately treated mental health disorders like depression and anxiety, may make some people more susceptible to substance use disorders than others. Once the brain has been changed by addiction, that choice or willpower becomes impaired. Perhaps the most defining symptom of addiction is the loss of control over substance use. People do not choose how their brain and body respond to substances, which is why people with addiction cannot control their use while others can. People with addiction can still stop using substances. It's just much harder than it is for someone who has not become addicted. People with addiction should not be blamed for having a disease, but rather be able to get quality, evidence-based care to address it. Like diabetes, cancer, and heart disease, addiction is caused by a combination of behavioral, psychological, environmental, and biological factors. Genetic risk factors account for about half of the likelihood that an individual will develop addiction. Addiction involves changes in the functioning of the brain and body due to persistent use of nicotine, alcohol, and/or other substances. The consequences of untreated addiction often include other physical and mental health disorders that require medical attention. If left untreated over time, addiction becomes more severe, disabling, and life-threatening. Addiction is not a social ill or choice. It is a brain disease. On the bottom, you see a healthy heart and a diseased heart. On the top, we see a healthy brain and a diseased brain. We don't claim individuals with heart disease had a choice in the matter, but we stigmatize individuals with substance use disorder as it being their fault. As we previously discussed, addiction is not just a disease, but a chronic one. A chronic disease is a long-lasting condition that can be controlled but not cured. 50% of people with substance use problems develop a severe chronic disorder. For them, addiction is progressive, relapsing disease that requires intense treatments and continuing aftercare, monitoring, and family or peer support to manage their recovery. The good news is that even in the most severe chronic form of the disorder, it can be manageable, usually with long-term treatment and continued monitoring and support for recovery. When you look at the disease of addiction compared to other lifelong, chronic, relapsing, life-threatening diseases, you can see that relapses are similar for drug addiction and other chronic illnesses. We don't treat people suffering with diabetes the same way we treat individuals with substance use disorder. When a diabetic's blood sugar is high, we don't shame them and say, "Why'd you eat that piece of cake?" Instead, we treat their chronic condition with acceptance and understanding. However, when an individual relapses from substance use disorder, we ask, "Why did you do this? Why are you here again?" We need to shift from treating people like that. This is a chronic disease, and we should expect chronic relapse despite treatment. Substance use disorder doesn't just impact the individual, but affects many areas of public health, including mental health, crime, family dynamics, unemployment, Hep A and C, HIV/AIDS, and homelessness. Improving on recovery significantly improves these challenges and the overall health of our communities. Addiction and other health conditions caused by long-term substance use are the #1 cause of death in the United States. Each year, deaths related to overdoses are doubling, if not tripling. Through current models, we are helping some, but we are losing the war. Opioid overdose continues to be the leading cause of accidental death in the United States. Approximately every 8 minutes on average, a person dies from an overdose. There are many reasons for overdose emergencies, and most often they happen accidentally and at home. The rate of all alcohol-related emergency visits increased 47% between 2006 and 2014, which translates to an average annual increase of 210,000 alcohol-related emergency visits. Alcohol contributes to about 18.5% of all emergency visits and 22.1% of overdose deaths related to prescription opioids. An estimated 95,000 people die from alcohol-related causes annually, making alcohol-related deaths one of the top preventable causes of death in the United States. Additionally, 14.5 million individuals between the ages of 12 and older admitted to having an alcohol use disorder in 2019. Less than 10% of people with past year alcohol use disorder receive any treatment. Additionally, less than 4% of people with alcohol use disorder were prescribed a medication approved by the U.S. Food and Drug Administration to treat their disorder. People with alcohol use disorder were more likely to seek care from a primary care physician for an alcohol-related medical problem rather than specifically for drinking too much alcohol. A moment of silence. So how can we improve outcomes? Medication-assisted treatment is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Medications used in med-assisted treatment are approved by the Food and Drug Administration, and MAT programs are clinically driven and tailored to meet each patient's needs. Medication-assisted treatment is evidence-based. The FDA has approved several different medications to treat alcohol and opioid use disorder. MAT medications relieve the withdrawal symptoms and psychological cravings that cause chemical imbalances in the body. Medications used for MAT are evidence-based treatment options and do not just substitute one drug for another. Acamprosate, disulfiram, and naltrexone are the most common drugs used to treat alcohol use disorder. They do not provide a cure for the disorder, but are most effective in people who participate in a med-assisted treatment program. They can be used for people in recovery, to treat chronic alcoholism, and block euphoric effects and feelings of intoxication that allow people with alcohol use disorder to reduce alcohol use and remain motivated to continue to take medication, stay in treatment, and avoid relapses. Buprenorphine, methadone, and naltrexone are used to treat opioid dependency and either suppress or reduce cravings, aid in symptoms of withdrawal, or block the sedative effects of opioids and prevent feelings of euphoria. Naloxone is used to prevent opioid overdose and reverses the toxic effects of the overdose. There is common misinformation regarding medical marijuana, or MMJ. MMJ is not a recognized medication-assisted treatment medication, nor is it medically recognized to treat any condition currently. Drugs, substances, and certain chemicals used to make drugs are classified by the DEA into 5 distinct categories or schedules, depending upon the drug's acceptable medical use and potential for misuse. Schedule 1 drugs are drugs defined with no currently accepted medical use and a high potential for abuse, and include heroin, LSD, marijuana, and ecstasy. Medication-assisted treatment platforms are not just about dosing out meds. Under CFR 42, medication-assisted treatment patients receiving treatment must receive counseling, which may include different forms of behavioral therapy. These services are required along with medical, vocational, educational, and other assessment and treatment services. Let's talk about some facts. Fact 1. Medication-assisted treatment saves lives. Using these recognized medications for opioid use disorder reduces the death rate among those living with addiction by 50% or more. Fact 2. Medication-assisted treatment reduces the chance of relapse and overdose. Not only does medication-assisted treatment reduces the chances of relapse and overdose, but criminal activity and transmission of infectious diseases are also reduced for those receiving treatment. Fact 3. Medication-assisted treatment provides a whole patient approach. MAT is tailored specifically to each individual. The medication relieves the withdrawal symptoms while counseling promotes positive behavioral and lifestyle changes. Fact 4. Recovery is possible. When the cravings and withdrawal symptoms stop, people who are struggling with addiction have time to focus on long-term goals, remission, and recovery. Up to 90% of patients who use MAT-assisted treatment remain sober at the 2-year mark. In a study conducted in 2003, 75% of the patients on buprenorphine retained in the study passed the 1-year mark, where all of the control study dropped out by the 60-day mark. More importantly, no one treated with buprenorphine died in the study, where 20% of the individuals treated with abstinence only did. We have to stop thinking of MAT as a replacement for illegal and misused substances and start shifting to an understanding of addiction as a lifelong, life-threatening, progressive disease that should be treated the same as other similar chronic conditions. In a recent release from the U.S. Department of Justice, the DOJ makes it evidently clear that prohibiting an individual from care solely based on their use of med-assisted treatment medications to treat their diagnosed substance use disorder is considered federal discrimination and prosecutable by law. Ironic that this is the same protection awarded under the ADA and FHA that protects recovery residences from NIMBY discrimination and discriminatory practices from local municipalities. Don't you think? Even Alcoholics Anonymous World Services recognized that some AA members had taken the position that no one in AA should take any medication and found it resulting in disaster for many of its members. AA World Services released a guide in 2018 regarding the use of medications of its members, which concluded it is wrong to deprive any member of medications which could alleviate or control disabling physical and/or emotional problems. We asked med-assisted treatment housing providers statewide to share their experiences with their residents and medication-assisted treatment. The data was collected on 105 locations, which covered 636 beds in different geographic areas of the state, with about a 35% bed turnover rate annually, equating to about a 223 bed rotation. The first question we asked was how long they had offered med-assisted housing. On average, providers had about 6 years of experience. We asked if they mixed or segregated their populations. All reported to having mixed populations. We asked if that was always their model. On average, the answer was yes. Providers who reported starting with a segregated model stated residents felt isolated, stigmatized, not part of the community, and didn't participate in recovery planning. Once they switched to mixed models, residents felt a sense of community, engagement, and participated in both fellowship activities and recovery planning. We asked how often clients had shared their meds. On average, there is one incident per year. We asked how often clients had abused their meds. On average, it's less than 1% annually. We asked how often clients had refused their meds. Less than 1% annually, though some reported residents wanting to taper off their meds. We asked how often residents requested to be put on meds post-entry. The response was less than 1% annually. We asked how meds are stored. 90% of providers reported medications as being staff held, though some providers allow the residents to store their meds in secure lock boxes and conduct pill counts weekly. We asked if there's ever been incidents where staff had taken resident meds. There were 2 incidents across the entire study. We asked if providers required a taper. 40% of providers required a clear start and stop date, with 60% of providers not requiring a taper at all. We asked providers if they restrict dosage. On average, 16 milligrams was the cap. Finally, we asked providers, is it working? The response was yes. What are the best practices for med-assisted treatment in recovery housing? Let's start with screening. Providers should screen for both substance use disorders as well as mental health disorders. Residents should disclose all prescription medications, including dosage and frequency, as well as a taper plan, if applicable. Providers should determine the appropriate storage site for medications with potential for abuse. Providers should follow the treatment plan from the prescribing physician and obtain a release of information to communicate with prescribing doctors. Residents should sign medication storage and usage agreements. The agreement should include that they will be monitored for acute behavioral changes for the extent of their time as a resident, including nodding, slurred speech, lack of normal balance, and inappropriate behavior. Rules and clear consequences regarding the abuse of sharing medications should be in the House Rules and Consequences. And residents should always express a willingness to participate in recovery programming. Suggested screening questions include: why were you put on the medication initially? How long have you been on the medication? What was your initial prescription and dosage and directions? What is your current healthcare provider's plan for you? What is your current prescription for the medication? Is your healthcare provider using any other medications in conjunction with this? And are you willing to sign a release of information for your prescribing healthcare provider? Red flags include unusual dosage or regimen for prescription, not willing to have release signed, resident having little knowledge of medication side effects or benefits to them, and resident has no initiative to follow the treatment plan. There are multiple safe storage options for any medications with the potential for abuse. Providers should look at their staffing model, protocols, and their community to determine what's going to work best for them. Providers can elect to completely store medications off-site at the prescriber. This requires no additional staffing requirements, no potential for misuse, sharing, or abuse, and no additional administrative needs. Providers can also elect for staff to hold on to resident medications. Protocols should be put in place for logging medications, medication observation logs, how residents can access their medications with a multi-staff availability. Finally, providers can elect that residents hold on to their own meds. Residents should be provided or required to have locked storage. Providers should conduct routine pill counts. In this model, providers have little administrative needs. Best practices for the usage of medication-assisted treatment medications in recovery housing include ongoing drug testing, wrap services like psychosocial services that treatment programs may provide to facilitate access, improve retention, and address clients' co-occurring problems, recovery assessment and planning which aid in the long-term recovery of the individual, and ongoing communication with the prescribing physician, noting changes to dosage and regimen in the resident's file. In conclusion, allowing the use of medication-assisted treatment meds normalize brain chemistry, block the euphoric effects of opioids and alcohol, relieve psychological cravings, and normalize body functions without withdrawal, all which aid in the ultimate goal of saving lives. We want to thank you for attending this training, and remember, with one person dying every 8 minutes from this disorder, we can estimate about 4 people have lost their battle while we discuss this controversial topic.